So we will discuss today about pterygoid implant challenges. Usually pterygoid is considered very challenging, difficult than other implants. We will see today how to solve those challenges. But for us to solve the challenges, we need to understand why it is difficult, why it is considered more difficult. Some even consider it is a blind procedure. The reason why it is commonly quoted as a blind procedure is because we are not seeing the other end of the drill. However, it is not true. We are not seeing the other end of the drill in the lower anteriors. We are not seeing the other end of the drill in lower molars. We are not seeing the other end when we are drilling the upper anteriors. But we are telling this as a blind procedure. We are feeling confident in other implants, but still we are telling this as a blind procedure. This is called a blind procedure because not because we are not able to see the other end of the drill, because we don't have sufficient knowledge in certain things. There are 4 things where we lack basics and knowledge. That is why it becomes challenging, it becomes difficult, and we are telling it as a blind procedure. The first challenge is to not realizing the key differences between pterygoid implant and other implant. Key difference. There is a key difference in pterygoids and other implants. And second difference is not understanding the surgical anatomy, not having a basic awareness about surgical anatomy and surgical planning, how to plan based on the anatomy. But also we treat it as a other area implants. And third area where we are blind is we don't know about the proper armamentarium, what instruments we need, what handpiece to use, armamentarium, and what implant design is suitable for pterygoid, and what is the ergonomics we should follow. Ergonomics means how we are making the patient position the chair, how we are standing or sitting. Okay. And finally, what is a proper surgical technique? What is the correct technique to place a pterygoid implant? So lack of awareness or lack of knowledge in these 4 segments is the reason for we are telling it as a blind procedure. It is the reason for avoiding pterygoids. It is the reason for starting pterygoids and not continuing it. It is the reason for not getting stability in pterygoids. It is the reason for getting complications. So it is the reason for everything. If you can understand these 4 segments, then it is like any other site implant. Okay. So we'll understand what is the key difference. Browser menu.
HDMI.
What we see is a full mouth rehabilitation with pterygoids, distal tilted implant and anterior axial implant. The common scenario is pterygoid, pterygoids, distal tilted and anterior axial. This is the standard format. Okay. When I ask how it is tilted, what angle it is tilted, So what will you see? What angle it is tilted? This middle implant. It is tilted in which direction?
Mesially.
Okay. So we know that it is mesially tilted. In which direction the pterygoid is tilted? Distally. In which direction the anterior implant is tilted? So it is not tilted, that means it is a axial implant. Right? Any other answer we want to add? No. Okay. Okay. So this understanding is the challenge. This understanding is the problem. Okay. This implant is not only tilted mesially. Okay. From this angle, it is tilted mesially, but from the occlusal side, it may be tilted, no, from buccal to palatal or buccal to buccal or palatal to palatal, whatever. This looks like a axial implant from this perspective, from the frontal view, but from the occlusal view or when you see in the CBCT, it may be tilted towards the palatal aspect. So it is axial on this one plane, but this is tilted on another plane. So all implants are almost tilted only, and tilting or inclination happens in two planes. From the frontal plane, what is the tilting? From occlusal view or from CBCT also you can see this. So from different plane, from two plane, there are two angulation is there. And not understanding this angulation, not understanding this tilting in two plane is not, it won't create much of a problem in this anatomical area. It won't create much of the problem in this anatomical area. But when it comes to pterygoid, not understanding the angulation in two planes, from the frontal, okay, or buccal view, and another from the occlusal view. Or it is traveling in two directions. We know it is traveling in distal direction, but it is traveling in another direction also. When you see from occlusal, it is traveling in medial direction. So the pterygoid is traveling in distal direction. Pterygoid implant is traveling in distal direction and also in the towards the medial direction or towards the palatal aspect or palatal angulation, medial angulation. So these kind of two angulations we have to achieve correctly. Distal angulation have to be perfect, the medial angulation has to be perfect. Even if any one thing is missed, the entire pterygoid is a problem. You cannot place a pterygoid implant or it will fail. But when it considered to here and here, some kind of error you can make, some kind of mistakes, some imperfection is allowed. No major problem will come. Okay. But here, those kind of small deviations or errors are not allowed because of the anatomy. Okay. So as I already told, there are 4 areas where we are blind. Now we understand the pterygoid implant is not blind, we are blind. First is understanding the difference between the other implants and the pterygoid implants. And second difference is surgical anatomy and surgical planning. This difficulty is due to lack of surgical anatomy and surgical planning. Okay. So when it comes to surgical anatomy, these are the two important views. pterygoid anatomy we cannot read, understand from only one view. We have to need two views. Because one is from the buccal, this is from the occlusal. Okay, first we will see the occlusal one because it is one of the key view. We know it is a tuberosity, which is a part of which bone? The tuberosity is a part of maxilla. So this green colored bone is the name is palatine bone. This extension is called the pyramidal process of palatine. Pyramid means something higher. Okay, so from this it is coming much higher. That is the pyramidal process of palatine. This bone, this bone, this bone is the pterygoid, not pterygoid, pterygoid wings of the sphenoid bone. This is a full bone. This is a full bone. It looks like a no wing. That is why it's called pterygoid wing. Ptery also wing. Pterygoid wing is also wing. So this is pterygoid wings of sphenoid bone. So three bones. One is the sphenoid bone. Another one is the palatine bone. This is maxillary bone. Tuberosity of maxillary bone, pyramidal process of palatine bone, pterygoid wings of sphenoid bone. So if we observe here, the key difference is the pterygoid wings are not positioned like this. Imagine this yellow is the pterygoid wings. They are not positioned just behind the tuberosity. They are positioned not only behind, medial. So if you go through here, this junction is entirely medial. So that is the key anatomical difference. Okay, so the implant should angulate medially. Okay, this is one of the key things to understand when placing pterygoid, because many times we see pterygoids placed here. When the doctor is telling I am not getting stability, that means the doctor is going through the lateral pterygoid plate. The lateral pterygoid plate is a very thin and paper thin bone which is not of a good quality, and not only that, here this huge dangerous space is there. It's called infratemporal fossa, and here this space is called pterygoid fossa. So placing implant here, the implant may slip into these two anatomical spaces. So to achieve success, to get stability, we need to tilt medially, and to avoid getting complications, we need to tilt medially. For both the reasons, we need to tilt medially. Okay. So from this view, this is the tuberosity, this is the pterygoid wings. Okay, this area is called the fusion zone, where the pterygoid and the maxilla fuses. This is the pterygomaxillary pillar. This is our target area. This is our target area. Above the fusion zone, there is a tear-shaped radiolucency. You can see in the X-rays. This is called pterygopalatine fossa or fissure, where important anatomical structures are there. We should not go till here, which is not possible unless we use a very long drill and longer implant. Okay, so going to this is almost highly difficult, going to this dangerous zone. Okay. So this is our target area. This area is our target area, not above, not below. Okay. So now we know where we have to target our implant. From the occlusion plane, we have to target our implant initially. From the buccal view, we need to target towards the fusion zone, not above, not below. Okay. There is a note.
Menu. And
Okay. Now we have to understand this much better about the planning. We know what we need to understand. What is the point and what is a path and what are the planes. Okay. Point is nothing but a dot. Okay. So when we are placing two dots and connect these two dots with a line, it is creating a path. Okay. So implantology is nothing but placing implant is nothing but creating 2 points and connecting those 2 points with a line. So when you are placing implant, when we are placing implant, okay. When we are placing a distal tilted implant, so this is one point, this is another point, we are connecting with a line and placing implant. So it is creating an implant path. It is like a journey. Okay. So 2 points create a line and a path. So this point is called the starting point. This point is called the target point or exit point or end point, whatever it is. We will see it as this is where we are starting it. Starting point, this is a target point. Like a journey, like a bus journey or a train journey, whatever it is. Okay. The key is we need to understand 2 points for pterygoid. Where we have to start ideally, where we have to end ideally. And we have to understand the path it is created by. 2 path. Okay. Why 2 path means from two planes there are 2 paths. From this plane it is going distally. From occlusally, if you see, this is the tuberoid, if this is the pterygoid, the implant is going medially. So there are 2 paths from 2 angles. From 2 planes. You are observing this in 2 planes. From this plane it is traveling distally, distal path. From occlusally it is traveling in a medial path. Okay. So this difficulty, we have to maintain the correct path in both 2 planes. That is only creating challenges. And that challenge is increased by the anatomical difficulties. Which is the maxillary sinus. Okay. If there is no maxillary sinus, then placing a pterygoid will be 50% easy. Okay. The only thing is we have to tilt the implant medially. But here the sinus is there. So the implant can go into the sinus. Right? So each and every patient will have a different sinus expansion. The less sinus expansion, it is a easy pterygoid. The more the sinus expansion, it is a difficult case because you have to operate within this less space. Okay. So the sinus is creating a additional challenge. We will see the we will see these 2 points and 2 paths one more time. So starting point and ending point or target point. from this plane there is one starting point and ending point. Okay. So how to determine the starting point? Comes under the plane. Okay. The starting point is measured, calculated from the distance from the distal end of the tuberosity. How much mesial from the tuberosity end or hamlar notch, whatever it is. So this is the distal end of the tuberosity or the hamlar notch. Both are almost in the same area. Okay. So from the distal end of the tuberosity, how much in front we are starting the starting point? Usually it is 10 to 12 mm. When the sinus is like this, usually it is around 10 to 12 mm. But what if the sinus is expanded till here? Okay. If the sinus is expanded till here, then placing starting from the same 10 to 12, we may go into the sinus. So we have to start still more here, from here. It may be 6 mm, 6 to 8 mm in front of the tuberosity. Okay, or even 5 to 6 mm. So commonly there are two starting points. One is 10 to 12 mm in front and another is 5 to 6 mm or 7 mm in front. Okay. So one is 10 to 12 and another one is 5 to 6 mm. Okay. But there is a limitation here. You cannot start from 3 mm in front. If you start 3 mm in front, this small tuberosity bone may get cracked up. So we should keep certain at least 3 mm of bone in this ear. Then only when we place the implant, this bone will retain, otherwise this may get cracked up. So we need to keep minimum 3 mm bone here. So if you start 5 mm in front, you can retain 3 mm bone here. So there are two starting points, 10 to 12 mm when the sinus is favorable, and another one is 5 to 6 mm when the sinus is not favorable. Okay. So ending point we know here. Okay. This is our target point, target area. But the problem is we cannot see this area surgically. So how to solve this? And you may be wondering how to see the distal end of the tuberosity. Okay. So we need distal end of tuberosity to start the starting point, to locate the starting point, and we need to see the fusion zone to actively engage this area, the target point. Okay. So how to find those 2 points? Okay. From this angle. Okay. So from this angle we need distal end of tuberosity for correctly starting the drilling, and to correctly end the drilling we need to see the fusion zone. If we make any mistake, it may lead to trouble. We may start here, we may start very here. Okay, and ending also we may end here, or we may end here, or we may end into the sinus. There are 3 mistakes are possible. We may end into the sinus, we may end in a dangerous place, or we may end in a non-fusion zone. This poor quality tuberosity bone we may end. Okay. And the starting point we may start very much and too much mesially, or we may start too much distally, leading to tuberosity fracture. So 2 mistakes can happen. One in this starting point mistakes either too front or too distant, or this ending point mistakes not too high, too low, and too front, whatever it is. Okay. Now the situation becomes a little more complicated when observing from the occlusal view. This is the starting point we know. The interesting part is the ending point. The ending point should not be here, otherwise the implant will move into the slip into the infratemporal fossa. It should not go into the pterygoid plate. It should accurately end in this fusion zone, this area, this pterygoid fossa area, or towards the medial pterygoid. There are two target areas here. One is either here, where the medial pterygoid lateral pterygoid junctioning is happening, the pterygoid fossa. This is the pterygoid fossa area. And another target point is this. This also you can engage, this thick bone. This bone is quite thick. Okay, so you can engage here also. Okay, so there are two target points. Anything will work fine. But how to find this correct medial angulation is another question. We may drill here or we may drill here, right? So we need to go correctly here. So theoretically it is around 10 to 15 degree angulation. Doctors will use clock method. If this is at 12 o'clock, go at 1 o'clock, tilt the drill at 1 o'clock position. This is one more technique. And one more technique is to palpate this bulge, this pterygoid annulus with finger and directing the drill towards that. Okay. The drawback of palpating and tilting medially is we may make error. Depending upon the thickness, bulge of the pterygoid annulus, depending upon the soft tissue thickness, and it is difficult to palpate and drill at the same time. Access difficulties, vision difficulties are there. Okay. So we need some landmarks here to accurately target this area. Okay. We'll see now. So what are those landmarks? In this view, what are those landmarks? This is a tuberosity. The important landmark is the distal most and palatal most point of the tuberosity. It's called the DP point. Distal most and palatal most point. If you can locate this distal most and palatal most point of the tuberosity, you can use this point as a reference for your medial angulation. Okay. So distal end of the tuberosity you locate and mark the distal most and palatal most point and angle your drill medially. You can feel the fusion zone with your elevator also here. Okay. So there is something called landmarks. When we write our clinic address, at the end of the address we will in bracket we will write near temple, near the tree, near the school, something like that. So what is landmark is? Landmark is something which guides us to reach the target. It guides us to reach the target. When you say near school, our clinic is near school. That means the school landmark is helping the patient to reach the clinic correctly. Okay, in the same way, if you know about the landmarks in pterygoids, proper landmarks, they will guide us to reach the correct pathway. Okay, so what are all those landmarks? So there are two kind of landmarks. One is the surgical or clinical landmarks, and another landmark is radiographic landmarks. So what are the clinical landmarks used? Okay, so if you are doing flapless, then you can use the clinical landmarks. If you are doing a flap, you can use the surgical landmarks. So which is the advantages, what is the pros and cons, we will see. So we will see the surgical landmarks. One is the tuberosity. Okay, more than tuberosity, the more specifically we have to tell distal end of tuberosity. Distal end of tuberosity. Why it is important? In what way it guides? It guides our starting point. Starting point, where to start? Whether to start 10 to 12 mm or 5 to 6 mm. We will be measuring with a probe from the distal end of the tuberosity and mark with a pencil, and you start the drilling. Okay. The second point is distopalatal point of tuberosity. Distopalatal point, which we saw before. Distopalatal point, it guides how much to medially angulate. Medial angulation it guides. Okay. So in the tuberosity there are two landmarks. One is the distal end. So from the distal end you will be starting your judging your starting point. How much mesially? You cannot start from 6. You cannot start close to the tuberosity. Okay. So correct millimeter we have to, correct length, distance we have to analyze. The second is distopalatal point. It tells the correct medial angulation. It guides us to tilt the drilling medially. If you are doing flapless, so what is the alternative is, clinically also you can check the distal end of the tuberosity. Right? Clinically also you can palpate over the gums, but it may lead to error. The soft tissue may be thick, okay, it may be mobile or something, so it is difficult to accurately judge the distal end of the tuberosity. And another distopalatal point which tells the medial angulation, how to do if you are doing flapless is by palpating the pterygoid hamless. Okay, but again the difficulties of inaccuracies will come. The pterygoid hamless may not give the proper medial angulation in all times, depending upon the thickness, height, bulge of the pterygoid hamless and the soft tissue thickness. The difficulty during surgery to palpate and drill at the same time. So opening the flap, you can clearly, accurately tells the distal end of the tuberosity and accurately tells how much medial angulation is there. The starting point can be checked by taking IOPA. Taking IOPA also will tell how much you are medially. If this is the drill, this is the tuberosity, IOPA will clearly tell. That is also one alternative. Okay. But this medial angulation cannot be verified by IOPA, cannot be guided by IOPA. You need to see the distopalatal point properly, or you have to accurately palpate the pterygoid annulus and tilt the medial angulation. Okay. If you are comfortable with palpating the pterygoid annulus, you can do flapless. Okay. If not, better to open the flap and see the distopalatal point, which gives more accuracy and predictability. We open the flap always because there is no amount of error is allowed in pterygoid. You cannot do one or two drillings then rechange it. It should be do it once, do it right. You cannot try many times. Okay. Now comes the radiographic landmarks. There are certain radiographic landmarks are very much useful during the surgery. Okay. So what are those landmarks? One is a sinus. This landmark cannot be seen clinically or surgically during the surgery. Only way is by taking the IOP. Your drill you might have started correctly, but you may be into the sinus. Okay. So you have to change the drill to here after taking IOP. So take IOP after a pilot drill. After pilot drill for 8 to 10 mm. After drilling, you take a pilot drill, RVG. So one landmark is the sinus. The sinus guides the starting point and the angulation in which you are tilting it. Both it guides. So what are the radiographic landmarks? One is the sinus and another one is this fusion zone, this thick radiopaque zone. Our drill should be aimed towards this area. The IUPA clearly tells that. So taking IUPA during surgery, during the pilot drilling stage is very, very essential. And of course, you can see the distal end of the tuberosity here also. Distal end of the tuberosity here also. Okay. So understanding these landmarks will help us to achieve predictability and success. Otherwise, it may be a hit and run situation. Sometimes you may get stability, sometimes you may not get stability. So planning these things before. We'll see some IUPs. Let us see the IUP here. I will draw the tuberosity here. Okay. Where is the sinus? It's not clear. Okay. Let us see, this may be the sinus. Okay. This is the notch. So this is our target area. So after pilot drilling we are taking this. If the pilot drill goes here, that means that we will change the angulation. If the pilot drill goes here, that means we will change the angulation. Okay. So one more thing we have to observe is, we are having a sufficient bone distal to the implant, this tuberosity. Okay. If we start the drilling like this, that means we will break this bone and this implant is not in the fusion zone. Okay. So taking IOPA is very, very essential. This is the tuberosity. This is the sinus. It is a transsinus pterygoid situation. We will see an ideal So this is a IOPA during pilot drilling. We will draw the tuberosity. Okay, we will draw the sinus. Okay. This is the fusion zone. This is the fusion zone. Okay. The pilot drill is going in the correct way. If the drill goes in this direction, we will rechange it. This drill goes in the, we will rechange it. And one more thing, if you observe, the drilling has been started about 12 mm in front of it because the sinus is very much favorable. Okay. So using these landmarks in the distal end of the tuberosity, the sinus lining, and this fusion zone. So in IOPA there are 3 landmarks you have to see. Okay. Sinus lining, sinus wall, then the distal end of the tuberosity, and then this fusion zone. Okay. The key thing is we should leave enough tuberosity bone distal to the implant, otherwise it may crack. We should not go into the sinus. We should not go towards this pterygomaxillary fissure. We should not go below the fusion zone. So taking IOPA will solve many issues. And this is the surgical view. Patient has got a huge tuberosity. Okay. And we can appreciate the tuberosity is turning medially. Okay. So this area, okay, this is the distal most and palatal most point. For this patient, the sinus was still here. The sinus was still here. So we are starting 6 to 7 mm from 6 to 7 mm from the distal end of the tuberosity. We are angulating easily. So once you open the flap, what are the things we can helpful is the distal end of the tuberosity we can see. Okay, so that you can accurately measure how much mesially you are going to start the drilling. If it is flapless, we may start here also. We may start here also. But now we know we will be starting here. This is the pencil marking. And how much medially we have to angulate. We will mark the tuberosity in the distal. This is the tuberosity. Distal most and palatal most point you will mark with pencil and measure 6 to 7 mm in front of the mesial to the pterygoid, distal to the tuberosity based on the sinus planning. If the sinus is very far away, we could have started from here also. From here also we could have started. Okay. So medial angulation is given by this distopalatal point. So if you open the flap, you will have 2 advantages. One is you will see the distal end of the tuberosity so that you can accurately determine the starting point. You can locate the distopalatal point of the tuberosity so that you can accurately tilt medially. And not only that, buccopalatally you can see the bone clearly and you can start accurately. If the flap is there, you may start here also, you may start too buccal also. The soft tissue may cheat us. So once you open the flap, you can accurately, it is most of the time it is mid-crestal or slightly palatal, not very much buccal. Based on the CBCT planning, you can determine that. We'll see one more picture. This is a surgical picture of open method. The tuberosity makes a medial turn. So we have located the distalmost and palatalmost point here, and we have located the starting point. It is around 5 to 6 mm in front because it is a sinus expansion situation. So we are starting from the mid-crestal. So everything is visible. All landmarks are clearly, accurately visible in this view. So you cannot make any mistake in medial angulation. You cannot make any mistake in starting the initial point. After pilot drilling, if you take IOP, it will become more accurate. If you see here, if we do with flapless, we may misdirect this implant like this. This is the lateral pterygoid, CBCT cross section, lateral pterygoid. This is the pterygoid fossa, this is the medial pterygoid. So the implant target is here. The implant should have gone from here to here. But instead of that, the implant traveled laterally. So the common mistake in pterygoid is not angulating not touching the correct medial angulation. So if you do two things, you can get more predictability. Start opening the flap and start taking IUPA after pilot drilling, and do planning before. The patient will be taken.
Rehabilitation.
People
No,